Thank you. Well, I thought it would be interesting at this point to review sort of where we've been and where we're going, but don't worry, I won't do it year by year. So it all started, of course, as I think everybody in the room knows, with a report in 1969 from the Li-Fraumeni pair who had done so much in cancer epidemiology. And what they observed in their study was unusual pattern of cancer, lots of cancers in families. And initially, I'm told, the impression was that this was an environmental problem. And they searched and didn't find any unusual environmental settings where some of these families came from. And when you look at a family like this one, where you have a consistent line of those affected and other consistent lines that are unaffected, that's really much more suggestive of a genetic syndrome. At that time, they really followed the families and were able to document the continued from generation to generation occurrence of this unusual pattern of cancers, which certainly supported genetics. That was confirmed in 1990 with the finding of the germline mutations in P53. And at that point in time, a lot was known about P53 in terms of its involvement in DNA repair and maintenance of genome integrity. So it certainly seemed to be a fit, not only as the well-known gene observed in tumors, but as a potential germline mutation causing this pattern of cancers. It didn't give us much idea about how to deal with it, though. What I began doing at that time was to set up a study of all the childhood sarcomas, soft tissue and osteosarcoma, that had been seen in our institution. And I was able to go back in time and collect information on the family history of cancer in patients who had been treated as long ago as the 1950s and 60s. Most of those children had died in those days. We didn't have good treatment, but because these were mostly families from Texas, they were very willing to help in any effort to understand what had caused their child's cancer and to provide information. So we collected family history information on all of these families that were willing to participate and that were locatable and so forth, and ultimately looked for P53 germline mutations in the patients. And among those that participated, we found basically 10% of the childhood cancer patients had a germline P53 mutation, both for soft tissue and osteosarcoma. So this at least gave us a feeling for how much this might be contributing to the childhood cancer sarcomas at any rate. We have followed these cohorts of a large number of families now. This is the total number of families, not all of them gave blood, but that's given us a chance to look at a number of different features in the syndromes. And one of the things that was always observed was that there appeared to be different risks in different families, and even a wide range sometimes in one family to another. And one of those risk modifiers that we were able to look at, courtesy of Arnie Levine and Gigi Lozano, was the role of the MDM2 SNP309. MDM2 was, of course, known to interact with P53, and this was an interesting polymorphism. And looking at our series of families and individuals, we were able to show that in the presence of this SNP309, there was earlier age of onset of tumors compared to those that did not have the SNP309. And as well, there was a significant survival difference. These are the wild type individuals. These are males with the wild type MDM2 and with the SNP309 with worse prognosis. And last of all, worst of all, were the females with the wild type MDM2 and with the SNP309 in the females. So we can see a very significant effect, not only on age at onset, but on survival based on this variant interacting with, that was known to interact with P53. So this gave us some further information about why one of the factors that could affect the range of cancer risk and outcome. The next question that will be discussed or is being discussed at this meeting in the workshops has to do with the risks of second cancers. And we all know that that has been just a major concern in the Li-Fraumeni syndrome families, and as well a major concern to everybody involved in working with them. Again, in these sarcoma cohorts, this is the group of individuals with the germline mutation, and this is the risk of a second cancer over time. And this is the risk in the sporadic, in other words, the non-mutation carrier individuals who had a much lower risk. And you can see that that risk of a second cancer occurs almost immediately. This is not something that only occurs 5 or 10 or 20 years later. It starts almost immediately. One of the issues in looking at this risk has to do with the effect of treatment. And again, in these cohorts, they were very informative. And this looks at the group that were wild type who had no radiation. And this is the group that were wild type and did have radiation and had a few second cancers. This is our group of mutation carriers who did not have radiation and certainly developed second cancers, but in most cases it was after more than 10 years. This is the group with the mutation who had radiation. And you can see that this risk of second cancers just starts almost immediately, and it just goes and goes and goes and goes. So we certainly know that radiation, particularly in this population, can be a significant risk factor. In today's world, I think everyone is well informed about this. There are efforts to modify the radiation therapy using proton therapy, or in some cases, alternate fields of radiation or other treatment modalities. But radiation for many, many years has still been a key player in treatment of some of the sarcomas. We've also learned through the advancement of genomic sequencing and such that wasn't available to us back in 1969, that a significant percent of the patients can be de novo mutations. In other words, they have no cancer family history. And on sequencing, we find that in many cases, neither parent carried the mutation, but of course, once it's in the germline, it can be passed on. Sometimes the patient may have more than one de novo mutation, one involving P53 and one just a random other de novo mutation identified because you've got samples on both the patient and the parents. This can be really important in families where, for example, they adopted a child without any information about the child's family history, and the child has a sarcoma or some other childhood cancer, and everybody is wondering, why did this happen? And in many cases, it is an unexpected but de novo mutation. So this is a worthwhile test, excuse me, when there's not a family history of cancer or an antecedent mutation that can be identified in the family. In 2011, David Malkin's group, as I think everyone in this room knows, published his data on the screening or surveillance program that they had developed here. And it was very impressive, I think, to all of us in the field, because we had tried a few short-term things, but it had been not really very productive in terms of early detection. At the time he published that, we were fascinated because we had a large number of individuals with germline mutations identified, but who at that time had not had cancer. And we really didn't have a well-documented program to follow them. But we had some 150 such individuals. We also had a large number of children whose parents had declined having them tested, but who were at 50% risk of being carriers based on the family history. And so we set up a program to sort of try to accomplish some of the things that David had. And this is just a definition of the program that started a few years back. The first thing is you have to assemble a multidisciplinary team, because you really need almost everybody in clinical oncology involved, whether it's pediatrics or any of the adult services. You've just got to have multiple imaging. It's a complicated group to get this many people coordinated and working together. So it's currently available to pediatric and adult patients who have a confirmed LFS diagnosis in terms of a p53 germline mutation. And we include people who have no personal cancer history at this time but carry the mutation, or those who have been successfully treated and have been off therapy for more than a year. So this has been a program that has been attractive to many of our patients. And we have heard from the literature as well as from patients that there are pluses and minuses of this program. So we decided to do something of a satisfaction survey, if you will. It was a telephone survey. Information was recorded and then transcribed so we could get actual quotes of what individuals said about the program. So the first question was, what did they view perceived benefits from the program? And you can see that the large percentage of individuals who responded did indeed perceive some benefit. I do have to acknowledge that not everybody agreed to go through and complete the survey, so the numbers who actually gave us data were not huge. But it was positive that the majority perceived benefit. Next, we asked what were the benefits that they perceived, and these are some of the quotes from the individuals. And some of them are ones we might expect, the fact that it wasn't a process or potential for early detection. It provided some peace of mind. They liked the idea of coming to one institution with centralized screening so that they didn't have to go multiple different cities or institutions. The sense of knowledge is power. And one that I liked was that LFS was more livable given that they had access to this program. However, they also had a number of drawbacks, and they were not hesitant to let us know about those. And of course, the most obvious one has to do with insurance concerns. And I think all of us have to work together to come up with some ways to resolve this, whether it's in the way we bill, whether it's in the recommendations for LFS patients generically, whether it's in the way that insurance institutions understand and know about LFS, but we have to work together to change this. This is just not acceptable. There are other concerns were about organization and navigation within the program. While it was a single institution, MD Anderson has multiple sky bridges across the streets and from one building to another. So it's not like you just go in one building. The whole body MRI is in an isolated building, which doesn't do very much else other than that. So it's really an isolated location when you're going through that part of the exam. They all commented, many commented that it was draining, and that within the week or so before their exams, they were incredibly nervous and anxious. They couldn't sleep. They didn't like to talk to anybody. They were concerned. But the majority still indicated that they wanted to continue coming. So this gives kind of a two-dimensional approach. But basically, with this information, we have tried to establish a lot more psychosocial support to try to help get through some of these stages of all anxiety before screening. But I think overall, it confirmed to us that this was a program that was of value and was important to the individuals. So in addition, I wanted to talk about some of the evolution, if you will, from the 1969, from the years of not knowing what to do, and even from the point now of having a screening program, to talk about some of the things that have come up at this meeting that I think are very exciting. The potential for significant improvement in many areas of management and potential control or greater control of LFS. I think the whole idea of the circulating tumor DNA that could be conducted at the time of the whole body MRI and then matched up with that at the next meeting if there was a match, a find in either category. I think this is tremendously exciting. And I know there's still some questions about it, but I think if one is going to do that kind of a test, there is no population for whom it would be more valuable to the patient and also more informative to the scientific community than the LFS population. Secondly, was some of the ideas that have emerged with respect to prevention and sort of management. The idea that we could develop a mutation that would be a specific, an antibody that would be specific to the P53 mutation that could potentially block the ability of the mutation to render its effects is very appealing, and I can't wait to hear David Lane in the next time. The idea of gene editing, where we could actually wipe out or eliminate, in effect, delete the mutant P53, certainly may be very something potential within all of our lifetime. And lastly, I'd just like to mention, I think the power of the LFSA. This group is dynamic. It's got lots of energy, lots of enthusiasm. It's already accomplished a tremendous amount to change the awareness of the syndrome, of the opportunities and potential for coming together to consider better approaches and management. And I think that that's a very important take-home lesson from this meeting. So I had a very short timeline here, so I wanted to just go through these thoughts that had come to my mind as we were looking at the opportunities we can think of for the next few years compared to those that were available back in 1969 and during the interim. So with that, I'll be glad to take any questions. Hello?
I have a question for you, Louise. So I was wondering, as a pediatric oncologist, do you find are there differing opinions from families with LFS as to whether the parents or the children want to pursue surveillance? I found in my own experience that parents will do anything for their kids, but sometimes when it comes to themselves, it's a little bit different. And I don't know what your thoughts or experiences have been on that.
I think the parents have been pretty enthusiastic about it as well. We have not had a lot of hesitation on the parents' side to participate. And depending on the age of the kids can nudge their parents in a way a little bit like the parents nudge the kids along. So it becomes a family affair. There are families who have been known to make a family trip out of it. They have to come to Houston, so they're going to have a family fishing trip, a group in this audience, and make something positive out of it for the group as a whole. So I think that's a good way to anticipate it, especially if there's travel and so forth associated with it.
Great. Any other questions? Oh, yes.
My name is Monica King. And I was going to MD Anderson at one point. So I would like to meet with you outside of here to talk to you about, no, it's not bad to meet with you outside of this and just kind of give you a little bit of my story. And because hearing you, it kind of makes me feel like I want to go back, but I left there before knowing that I had LFS, had tested positive. So it'd be nice if I could just get with you and give you my information and see about talking to you.
I would be happy to meet with you and hear your story and try to see at what interval that occurred and where we were at that time and so forth. But I'd be very happy to meet with you.
It was 2 years ago that I left there, but it was funny. You and I were just kind of walking on the sidewalk trying to find this place, and I didn't know that it was you.
Sharon.
So, hey, I say, God puts you in places where you need to be.
All right. One last short question, Sharon.
Well, to just follow up, I think, at least in the United States, not Canada, where we are currently, there's often a big difference in insurance of children versus parents. And so we've run into, being across the street from Louise, we've run into a lot of issues where the children are covered, for example, in Texas under CHIP or something else, but the parents are uninsured. So in states it didn't expand Medicaid, for example, or things like that. And so I do think it's a real dynamic, because it's certainly true as the kids become adults as well, that their insurance status can change in the United States, at least. Fortunately, not in many of the rest of the countries represented at this meeting.
Yes. Thank you.
All right. Thank you, Louise.